Our next session this afternoon is Safe Care Possible. Our clinical educator, Susan Blankenship, is going to introduce the people working on this along with her.
Good evening. My name is Susan Blankenship, like Sheila said, and we work in a core group, Sandy Sayer, Becca Bishop, and Lisa Dishner. And so they're going to go ahead and talk about the presentation, and we'll be around for questions afterwards.
Thanks. Many of you guys have heard about this project a little bit that we've been working over the past 2 years, really. And go ahead and start. It all stemmed basically from an attempted inpatient suicide that occurred in CRMH. We dove into this and kind of built a whole team. It grew arms and legs before we knew it. Next thing you know, we have all these different departments involved. And we really dove in and did deep analysis of the attempted suicide, and then actually how risky were we in this environment. And we learned, we did some site visits, and we learned it's more of a global problem. All hospitals are having a hard time really having a safe environment for this high-risk patient population. Went to Catawba. We even did a lot of work over with the annex in here, as well as over at inpatient psych. We went to UVA as well. And it just became apparent that there's a lot of loopholes and a lot of challenges. So we just set our goals, and this was what they were. We wanted 0 psychiatric serious safety events. Really wanted to improve our environment and have a safe environment, and really come with a standardized care. There was different processes and all kinds of things. We wanted to kind of streamline that as well, and also decreased risk for collateral damage associated with staff members. One thing that when this happened, we didn't take in, we kind of didn't really think of it into the depth that it was, but your employees, the impact that it has on employees when you have an event like this. And we got to interview those employees as well that are not working at Corona anymore, and that was quite interesting and very eye-opening. So we started with developing our research model, what we were going to do, how we were going to conduct our study, and we came up with 50 patients that we audited and went through, looked at our current process, and basically went through the house. And all 50 patients, Lisa will talk about that a little bit, we did audits on them from December 7th through March 28th of 2013, and there were multiple areas of risk that we identified. So our team set up weekly meetings and just kind of dove into all of that as well.
Some of the interventions with the new process that we started February the 22nd of 2014 included a revision to the policy that we currently had, our suicide precautions in the acute care setting. We had to add things like searching the patient once they became inpatient, adding some order sets, as well as the lock safety carts that we implemented in-house. The policy revisions went through both the adult and pediatric councils for approval before implementation. The next thing that we did was get an order set together for both suicidal and homicidal patients in-house to make sure that that was including the key elements from the policy as physician's orders to help increase compliance. We did have some EPIC enhancements, such as firing a BPA for the suicide care plan to increase compliance with that. We added flow sheets into the doc flow sheet for nurses to assess for risks of patients, which is something that our previous policy had stated, but there was really nowhere for the nurses to document, so we had that addition added. And then we also streamlined our education by creating suicide curriculums that were auto-assigned to employees throughout Carilion, where previously we had 3 various modules that employees could be assigned for education, so we got rid of all 3 and created just 1. We created family and patient educational brochures. A lot of times when patients were put on these precautions, there was really no education piece between the patients or the families as to why we were doing what we were doing. So we created a brochure to kind of explain those things so that they were aware of what was going on. And we had a very structured timeline for our education, communication to staff, and how we would implement that. You can see in the picture we had 10 locked color-coded safety carts. Purple is kind of a national color for suicide awareness. so that's why we chose that color. And each drawer has a very specific way for organizing. We had personal care items, any education. We had a copy of the policy in the top drawer, signs for doors to alert visitors, the educational pamphlets. It came stocked with the paper scrubs, cloth linen bags, and paper trash can liners so that staff could really work to make the environment safe. We have a drawer for visitor belongings as well as patient belongings so that those things could be kept outside the room. The results from the study, on your left you see pre-intervention from the dates of December 7th, 2012 through March the 9th, 2013. And you can see our scores weren't that great. Prior to the things that we changed, we really had nothing that was 100% compliant. Post-intervention, you can see on the right, our scores greatly increased to make a safer environment for both the staff and patients. This is more compliance, our pre and post-intervention results. On the left, again, that's the pre-intervention, and you can notice there for one portion, the patient wanted by security, we were actually 0% compliant pre-intervention and increased some compliance to 32%. Still some work to go, but it was nice to see an increase in the compliance. On this slide, you can see that we did meet a lot of 100% compliant as far as having a site consult and utilizing the suicide risk care plan so that we could follow our policy. Are there any questions?
And I noticed that what you were really measuring more than anything was staff compliance with the policy. And clearly there was, you did a great job in educating because there was an increase in compliance. The question I have is, did you at all keep measurements of how many patients you were dealing with at any through the course of the whole project that were on suicide precautions?
Repeat the question, please.
The question is, did we keep any data on the number of suicidal patients during the project? And basically what we did is we went to the IRB and got permission to do the study and to get into the charts of any suicidal patient. And so we just decided that we would take the first 50 once that we started. We audited them one time, and then we didn't go back. We corrected all the things that we could correct at the time. But the compliance really came in alignment with putting the orders into the order set. And the only way the staff can get the purple cart, which they absolutely love, is to order the order set. So it drove all the policy components into practice, or most of them. The ones that are 100%, that's probably why. But so we did 50, and it took us, how long?
From December to March.
And then, so there were 50 in-house during that time.
On any given day, you can pull to see how many people are on a one-to-one suicide. We work in the resource, I work in the resource pool, and we work directly with the one-to-one POAs, patient observation or old sitters, they used to call them. So daily, we round on staff, and then we follow up on them as well. There's actually in the rounding tool now, they have a suicide check. So that's one of the items that you can, when you round, you can check for safety in those rooms. So that's an addition, and that's huge.
Are there plans for a follow-up to go back and see how the compliance rates are now?
Yes, we actually have been discussing that, and we are going to be implementing another round of audits, yes.
So they were asking to see if we were going to follow up to see if the findings have been sustained, and we do have that in process. We have to go back through the right channels because of it being such a sensitive issue. And and on any given day, we have 9 carts in-house and 1 over at rehab, over at community. And so we've never had an absence of carts, but we've had all 9 out on the same day. So we did a SIM to begin with to see what our population was and how many we needed to order. So it is a real in-depth analysis of that.
How were they identified? How were the patients identified?
By coding.
By the emergency room, or who was the one that basically said they're suicidal?
That's usually in the emergency room, or if they're deemed suicidal while they're inpatient, if they get suicidal ideations during inpatient care.
So the status can change while they're on the unit.
Correct.
Yeah,
That has to be in order, right?
Correct. It's driven. It's physician driven.
Yeah.
So the physician feels the question was, how do you know who's? It's the physician draws it.
And what does the signage say on the door that
Oh.
alerts?
check it nurse, the signage on the door says check it nurses station.
Okay.
Visitors check in.
Visitors check it nurses station.
And have you had good compliance with that?
Really?
We have had
Yeah,
good
we
compliance with
Okay.
that.
There are visitors that don't stop at the door and come in, but the POAs and the sitters have been trained to ask them to step out so that all of their belongings can be secured as well.
And we'd be amiss not to go ahead and mention that we're actually in revisions at this particular time because of the near miss that recently occurred during transport from inpatient here to inpatient rehab in the psychiatric area. And we had some contraband that was physically carried over by the patient, and so we're in all these revisions of policy revisions and making it a safer transport time whenever we do have these patients go over. So this is just ongoing work for this committee.
The visitors have seemed to bring things in at times.
Right, are visitors wanted?
Visitors are not wanted.
The question was, are visitors wanted and not inpatient here, but they are when they go over to inpatient psych. Questions?
Have you started writing for publication yet?
We have
We have
picked
several.
our art. She asked if we were working on writing for publication, and we have chosen our magazine, and we are trying to pencil in the time. And then we were well on the way of it, and the event occurred with transport. So we're back into the mode of trying to fix some more of the process issues to make it a safer environment. So, but that is in the works.
Thank you, guys.
Thank you.